Good afternoon and welcome to the Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. Today I want to welcome Dr. Trinh. Dr. Trinh is the Associate Medical Director at Houston Hospice, the city's oldest, largest, not-for-profit hospice care provider. She joined Houston Hospice in 2007 and serves as the education liaison. I really want to welcome Dr. Trinh today because this is one of my favorite subjects, and I think it's the most misunderstood subject there is, and I'm waiting for her to enlighten us today. So Dr. Trinh, welcome.
Thank you so much, Donna, for the opportunity to provide some of this information. And I'm glad that we're able to address this. Like you said, there's a lot of patients and families who may benefit from hospice, and they may not understand some of the pros and cons that are out there. So I'm glad about this opportunity to help make sure that we can reach as many patients and families as we can.
Awesome. So I'm going to say a scary word, meaning there's no hope or I'm going to die right away and you're putting me on hospice. What is hospice exactly?
And that's the key, is hopefully whenever that concept of hospice is introduced, then patients and families can realize that it's a service that has a group of interdisciplinary team members, or just a team of 6 people. The nurse, the doctor, the social worker, the chaplain, a volunteer, and bereavement coordinator. These are 6 people across the board, regardless of which hospice. They should be able to provide the comfort, both physical, emotional, and spiritual support that patients with a terminal diagnosis with a life expectancy of 6 months or less, who may benefit from getting that kind of support in whatever time they have left.
So you said in 6 months or less. What happens if I don't die in 6 months?
Oh, that's a very good question. There are certification periods that hospice teams get together and discuss about how the patient is doing. And if after 3 months, that's the first certification period, and the patient is recertified, then there's another 3 months when the patients are then recertified. And then thereafter, it's 2 months of time. The team gets together and discusses whether or not the patient's condition still qualifies them for hospice. Many times, patients who, especially the non-cancer diagnoses, patients who still appear to be very weak, losing weight, less able to ambulate, walk around, less able to do things they used to do, they still qualify for hospice, even though they may still be more than a 6-month period. So yes, many times, especially those little old ladies with heart failure, who you don't know how, but the little amount of blood that their heart is able to pump, where they're still talking and very pleasantly able to interact, would you be surprised if they were to get suddenly very weak and needs severe support at any moment? The answer is yes. And if that's the case, then hospice is likely appropriate for them.
But it sounds like someone could be in hospice for a year if they qualified.
And the answer is yes, as a matter of fact, if their condition can be documented that they are declining and needing more and more support and needing more and more medications especially. And when families are less and less able to help take care of the patient because patients can no longer do things they used to do, sometimes there's a lot of goal setting that patients and families need to have discussed, especially spiritually, with the social worker, the chaplain, as well as the symptoms that are likely worsening along the way.
Who pays for hospice?
Oh, good question. So especially with all of the mentally and physically exhausted patients and families out there, when you face a terminal condition, you shouldn't have to deal with the payments that have to deal with hospice. So when it comes to Medicare patients, 100% of the costs are covered. When it comes to Medicaid, private insurance, HMOs, typically those include a hospice benefit that requires co-payments, coverage guidelines, deductibles. And that depends on the insurance. To find more about the hospice benefits, I would encourage to call that insurance company and ask ahead of time. Hopefully you'll never need those benefits, but if you do, you'll have the information in your back pocket so that you know what to work with.
So why would I consider hospice for me or one of my loved ones?
And that's always a hard question. When is the right time for hospice, right? Oftentimes, patients and families who are just exhausted after having gone to emergency rooms multiple times, gone to the intensive care units and had tube in every orifice, and the families are having a hard time with the decisions, but the patients also having a lot of symptoms, having to go in and out of hospitals, in and out of clinic visits. When patients and families are ready to let go of the curative therapies, that's when the comfort measures of hospice would be able to help guide them to continue care, but with the goal of comfort as opposed to the goal of cure.
You know, I'm going to share a personal story. My mother was on hospice. Congestive heart failure, in stage, bedbound. She had just lost her husband, and we took her home, and hospice was a great resource for us. And although she wasn't seeking aggressive care, she had a blast. She had a blast with all the people coming in and out. She got to drink her wine because it didn't matter. And she was a bingo nut. She even went to bingo.
Oh, that's wonderful.
So she had a quality of life that going back and forth to the hospital and the doctors weren't able to give her.
There you go.
And I feel like I needed to share that story because it made the end time easier for me and my family, but for her too.
Absolutely.
Because I was totally happy that she wasn't just waiting to die. She actually had more life and quality in a very short period of time.
Oh, thank you for sharing that story with us, Donna, about your personal experience. That must have been a comforting one then. And the truth is, that's the hope, is that we can take away the obstacles that are keeping patients from being able to enjoy time with family, like pain and shortness of breath and all the symptoms that may come from these life-limiting diseases, and to help patients to be more interactive and build a legacy and build those relationships in whatever time they have. That's wonderful. Thank you.
So if we have a patient, let's say, that has breast cancer and we're at the end stage, but the patient gets pneumonia, are we going to let them go untreated? Or do we treat the pneumonia or the urinary tract infection? Or how does that work?
Excellent question. And many times that's one of the key concerns that keep patients from signing on to hospice. And we don't do lab tests or x-rays, so there's really no way to confirm those diagnoses. But really what we're hoping is to address the symptoms. If giving oral antibiotics would be able to help with shortness of breath for pneumonia, like symptoms, or if giving antibiotics would help with that burning and that pain from having a urinary tract infection, then the answer is very reasonably yes. As long as the patient can swallow, even if it has to be crushed, then it's reasonable to offer a trial of the antibiotics to see if it can help. Now, the truth is what antibiotics typically do is stave off the infection so the body can heal.
So what is the difference between home health and hospice?
Excellent question. So a lot of times the perception is that, well, they give the same services. But the truth is home health has a few requirements that hospice doesn't have, as a matter of fact. Home health is a medical model, and it's mainly addressing specifically the patient's physical condition, so that if they needed to continue antibiotics, patients would be able to continue antibiotics or dialysis treatments or chemotherapy specific to that medical condition. And patients are required to be homebound when they're on home health. But however, on hospice, you don't need to be homebound. As you mentioned, as long as patients can get up and go, we hope that they can go to the park, go to a store, enjoy time with family, be outdoors as much as they would like to be. And when it comes to hospice, there is a dedicated doctor who is obligated to, even in the middle of the night on weekends and holidays, pick up the phone and help address, make medicine changes and make medical recommendations to help guide the patients and families to be able to be comfortable.
What if my mother is in extreme pain or having shortness of breath in the middle of the night? And I know with hospice, you don't call 911 because you've usually signed a DNR.
Right.
And everybody wants comfort care, but she needs something now. And I call you. Pharmacies around here aren't open in the middle of the night. What happens with that?
Absolutely. And that's one of the key benefits on hospice is there is a nurse, even on a routine home care level of care. And there are 4 levels of hospice care. So routine home care is one of them. And we'll talk a little bit about that, where, like you said, even in the middle of the night, if medications need to be called in, it can be called into the doctor can address that. There's a nurse 24/7 who will pick up the phone and ask and be able to access the patient's medical records and counsel the families with the medicines that are in the house, order with the doctor's order, who answers in the middle of the night for new medicines to be called out and delivered directly to the home so that the patients and families don't need to even leave the house in order to get that new medicine to get the patients comfortable. And the truth is that coordination of care is something that's very unique on hospice, that we would be able to provide that comfort in that way. There's also a social worker or chaplain who can come directly to the house to make sure to address any questions or concerns. They come usually once initially and then as needed on routine home care, once a month as needed. And then there's also the volunteers who either can help to purchase the groceries for the family or just to be there with families so that the caregivers can maybe get a little bit of a break while the patient can still be taken care of in that way. The bereavement coordinator is the key person that is unique to hospice. Unlike other clinical systems and active therapies, the bereavement coordinator can follow the patients and families up to a year after the patients are gone. And that way, the families can get some support through mails, calls, and even support groups. And then the physician will oversee the care and make sure that if there's any needs for the medications, the pharmacy, all of that is coordinated through the physician. If the symptoms get very severe, then you have the second level of hospice care called the inpatient level of care that can actually, where the patient can be transferred to a 24-hour facility, and there, like at Houston Hospice, you get injectable medications where sometimes patients don't have medications by mouth that are just as effective, so you have to go into an inpatient facility to get medication changes that can address that much more quickly. And the nurses there are 24/7 so that the nurses can give medications and address their concerns much more rapidly. There's the third level of care that is called crisis care, where if the patient desires to stay at home and the symptoms get uncontrolled, you can have an extra nurse come into the home up to 24 hours a day. And hour for hour, we have to document why that nurse needed to be there, because that is a much higher level of care. The fourth level of care is called respite, and the fourth level of care is for the family. 5 days where the patient can be transferred to a 24-hour facility like a nursing home usually, where patients can be fed and cleaned and kept comfortable so that the families can either take a break, go to a wedding, go out of town. Whenever one of the patients came in for respite to the inpatient unit where I work at Houston Hospice. The family would come in every day and sit with the patient and hold their hand and watch TV. But they were comfortable and relaxed because the family didn't need to clean and give medicine and make sure that the patient was fed. They could just let the hospice team do it, and then the family member could relax and rest and recuperate during those days. So those are the 4 levels of care. Across the board, all hospices have the obligation to offer those services, but the quality of the care won't be the same across all hospices. So typically, if I say you wonder which hospice is the right one, because there's so many out there, then I would say go visit them. Go get a gut feeling and talk to the people who would care for your loved one and see maybe whether or not that's something that you might want for your future.
So my doctor suggested a hospice company to me. Do I need to go with that hospice company, or can I make a different decision if I need to?
You can always make your own decision. It is the right of the patient and families to choose whichever hospice you would like. Typically, when you go into a hospital setting, the social worker gives a selection, and it's a short list because if there's so many hospices out there, how can patients and families choose? But if the patient and family wanted a specific hospice, that is always their choice.
So what if I get on hospice and I'm going through this and I decide for whatever reason, I don't know if I really made the right choice? What happens then?
It's not a one-way street. Patients and families sometimes, for example, they feel better after they get on hospice because we did help to resolve symptoms of the pain and the nausea and the shortness of breath. And then they second guess, are we doing the right thing? Are we on the right track? They may need to go back to the hospital and have a talk with their primary care doctor, their oncologist, in order to see whether or not they can get a little bit more chemotherapy, because patients and families always want to know, have they done everything that could be tried? And they need to be able to get to the point where they're able to accept the natural progression of the disease after that, when they can then sign back on to hospice. But they need to revoke hospice services and go back to their primary team of the curative therapies in order to then get those answers done, because we don't do lab tests or x-rays. And the reason we don't is because it would not change the way we would treat the patient and help the families.
Would a patient not take any medication? So I come on for cancer and I have hypertension and a prolapse valve and all this stuff. Would I come off my Coumadin and all that while I'm on a hospice?
Oh, excellent question. And that's also one of the key reasons why there's a long discussion when I first meet up with patients and families who sign on to hospice. I want to make sure to understand what their expectations are and what it is that I can do to help them reach those expectations. And if some of those are that they would like to continue their prior medications, the answer is if the medications are associated with the hospice diagnosis and therefore symptoms, then yes, hospice would provide that. Now, if the medicines are not related, the patients can still have those medicines, but they're covered like it was covered before the hospice diagnosis, before the patient signed on to hospice. So the answer is yes, they can have those medicines, but that may be in the context that some of those medicines might not be as beneficial as they used to. In fact, they may actually cause some element of harm, but if the patient needs to have it in order to feel like they're getting care, then it's reasonable to have it for that period of time, the trial period, to see whether or not it might make them feel worse.
Dr. Trinh, I want to thank you for this conversation, and I'd like to have more conversations in the future because I really feel like this is a benefit that people would take advantage of if they truly understood the benefit. For me, it gave me peace to have the support of a team to come in and tell me I wasn't the worst daughter in the world, or, I wasn't doing harm to my mother. And to see my mother so happy. She passed away in July and we had Christmas.
Oh.
And we had New Year's and we had all those things that she enjoyed. And it really, if losing someone that is so near and dear to you can be peaceful, hospice helps you realize that dream.
Oh, thank you so much, Donna, for sharing that. Absolutely. That's what we hope, is to be able to help patients and families build those connections. And yes, if we would be able to have earlier referrals, then we can have the time to build those connections much better. And that's really the key, is being able to reach patients and families when they can still make decisions, when patients can still verbalize what it is that they do or don't want. And then, like you said, so that families can feel like the patients are being taken care of and that you're never alone, because we're a safety net. That's what we are. So that you can always have somebody to call, and that we can reinforce this is the kinder way. You're neither prolonging or shortening. You're just helping the patient in whatever time they have.
I know that you have to have a doctor's order or referral for hospice. But can you educate yourself first before you go to your doctor?
Absolutely, yes. And there is a Houston Hospice website. If you go to it, houstonhospice.org, you will be able to see some of the information that you may be able to help learn about the initial information about hospice and what's required. And the truth is, anybody can refer to hospice. It can be a family member, it can be the nurse taking care of the patient, it can be cousin who may be able to see from a third party from the outside something that the direct family members may not be able to see. And then the referral visit is free for hospice to be able to come in and give the information and sit and chat. Many of our patients are referred to hospice and don't actually sign on until 6 months later or a year later, because they may need to be able to understand the relationships of the hospice and how they can help families. So sometimes it just takes a little bit of time for that information to sink in, and that's okay.
So we're running out of time, but real quick, can you repeat the website again? And if you have a phone number, give people a phone number to call.
It's houstonhospice.org and no space. Then the phone number 713-468-2441.
Thank you so much for joining us today. And a big thank you to our listeners for tuning in. Beginning now, set an intention and a relentless focus on living your life as the greatest person you can be in all situations. Don't forget to join us next week.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.